here to discuss Mothering in Mississippi, the state of maternal health, access, and outcomes, and the path forward, please welcome Lejeune Johnson, founder and CEO of Therapy Plus, Lauren Jones, co-founder and executive director at Mom.me, with Isabel Taft, community health reporter at Mississippi Today.
Thank you, everybody, for coming. Thank you so much to Lejeune and Lauren for being here. Can you all hear me okay? No? How about this? Yes. Okay, I think if we tilt them toward us. And I want to say at the top, we've had a couple of changes in the lineup, and so really appreciate Lejeune and Lauren rolling with the punches. And I think this conversation may end up focusing significantly on maternal mental health, but we're going to talk about a lot of different things. Before we get started, I want to say a little bit more about each of our panelists. Lejeune is the founder and CEO of Therapy Plus, and focuses on Mississippi families and children in her work. She also has worked with state agencies, including the health department, and has been a member of the Maternal Mortality Review Committee evaluating the pregnancy-related deaths in our state. Lauren is the founder of Mom.me, which is a nonprofit that advocates for Mississippi women and raises awareness around perinatal mood disorders, including postpartum depression and anxiety. So thank you so much to both of you for being here. To kick things off, I wanted to share a little bit of information about kind of the landscape of maternal health in our state. The most recent maternal mortality report earlier this year shows that our maternal mortality rate recently increased to 36 deaths per 100,000 births. Outcomes for Black mothers are significantly worse and are worsening, 65.1 deaths per 100,000 live births, which is more than 4 times the white ratio. Infant mortality, we continue to lead the country in the rate of stillbirths and deaths of babies under 1 year of age. Rates are worst in the Delta. Labor and delivery unit and neonatal intensive care unit there have recently closed in the last year or so, and those changes disproportionately impact Black families. In addition, the legislature has recently extended postpartum Medicaid so that moms can get health care for a year instead of 60 days after birth, but we continue to be one of 10 states that has not expanded Medicaid, and 1 in 6 women of reproductive age lack health insurance, which limits their access to preventive care to address chronic conditions before pregnancy. So having said all of that, I wanted to start by just kind of inviting Lejeune and Lauren, each of you, to share just sort of your sense based on your work of why we are seeing these statistics that are so troubling and so wrong. Lejeune, would you like to start?
Yes, sure. So I think for in anticipation of the maternal mortality review report that came out in January, I think that many of us in the maternal health care space were aware that Mississippi was facing significant challenges with our maternal health care system. But when that report was released, it was confirmation that our maternal health care system was in an abysmal state. And when we look at the report, there are several focal points that are very disturbing. When we talk about racial disparity in maternal mortality, I'm always very conscientious to be very delicate about this topic because we want to acknowledge that a maternal death is a tragedy of great magnitude, irrespective of a woman's race or her socioeconomic background or where she lived. That loss significantly impacts that woman's family and the community in which she once lived. And so we want to take a moment to acknowledge that loss. But when we look at these numbers, we also have to task ourselves to get uncomfortable and look at the numbers when we see the disparity that exists, particularly with Black women. We saw that the state overall had an 8% increase between the first report and the second report. But we also see that deaths increased 25% for Black women in between the first and second report. But we saw that deaths decreased for white women between the first and second report. What really drove the maternal death numbers up in the state of Mississippi were the deaths of black women. And so when we see those numbers, we really have to task ourselves to start evaluating why. Why do we see these numbers increasing at such a staggering rate for black women? And we really have to start to introduce the topic of talking about implicit bias, discrimination, and racism that exists in healthcare.
And I'll just piggyback off of what LaJune just said. I think we definitely have to start the conversation around race in Mississippi and our own biases, especially within the healthcare community. If you are here today and you work in the healthcare community and you have bought into the old notion of black and brown people feel pain at a different rate than other people, then I personally challenge you to do some soul searching and to really look at the level of care that you are offering this same mother that was, she's here with the same 10 toes, 10 tips, So if our physical composition is the same and I'm able to birth a child just like my counterpart, then why are we as black and brown women dying at a much higher rate? So I think we need to open the harsh conversations about race and how that actually plays in our healthcare outcomes here in this state.
Absolutely. And a kind of specific area of focus, I think, in our reporting at Mississippi Today has been the general lack of healthcare providers in our state. We don't have enough. In particular, we don't have enough who take care of women. We have a shortage of obstetrician and gynecologists. One study puts us at 50th in OBs per capita. We don't widely use certified nurse midwives, a lot of shortages across the board, but that also is reflective of a larger problem of brain drain in our state, lack of professionals in physical health, but also mental health. And so I wanted to just talk a little bit about how the lack of access to providers can affect expectant mothers. And Lauren, I was wondering if you could share a little bit about how you see the women that you work with and perhaps yourself, what do they encounter when they try to access care, access a provider?
Yeah, so as she mentioned, I'm in maternal mental health services. And the thing that we're seeing the most of course, there's a rise in anxiety stemming from COVID, but there's also a rise in anxiety around the birthing community is getting whim of the statistics and the number of women that are dying. So birthing a child is not always a joyous occasion, especially in this state, right? I want to know that at the end outcome is that I'm still going to be here for my baby when my baby's born, and that my baby is going to come into this life breathing. In addition to that, this past year we launched a new program, a maternal education program. And the thought behind that program was to introduce mental health services and mental health disorders earlier during pregnancy. But what we came to a realization was this is a far bigger problem. And we've had several women that have gone through this 8-week program that come to us, and they're 3 and 4 months pregnant and have not even been to their first OB visit, and express to us that they don't even know where to start with finding a healthcare provider, or they're waiting on Medicaid to kick in. So we have some major challenges that we have to overcome here in this state.
Just to add on to what Lauren was saying, two things can be true at the same time, right? Pregnancy can be a joyous, exciting occasion, but it can also be stressful and overwhelming as well. I did want to circle back around to the conversation about why people are leaving Mississippi, because I think that is important, because, when our talented people, our talented professionals, our talented students, decide to make the decision to leave our state in pursuit of other opportunities or better opportunities, that does impact the people who stay behind, right? And it does adversely impact our healthcare infrastructure. And so, unfortunately, this is not a new phenomenon that we see in Mississippi. People leaving Mississippi has probably been a challenge for as long as Mississippi has been a state, to be honest with you. And it's unfortunate. I mean, according to the recent U.S. Census data, we can look at the numbers. People are leaving Mississippi. But when we take a bigger look at the picture, we also see that our neighbors are gaining people, right? So states like Tennessee, Texas, Florida, people are going there. And so, we really have to task our elected officials, people in positions of power, to look at this and investigate the why. But I think, if we really look at the facts, it really boils down to better opportunity. It boils down to socioeconomic opportunity. It boils down to educational opportunities and healthcare access. And these things are factors that drive the quality of life that are important factors in why people want to live where they live. And when we look at socioeconomic status, Mississippi is the poorest state in our nation. That's a big deal. We also know that when it comes to education, historically, we tend to be at the bottom. When we talk about healthcare access, I think I looked up, Mississippi continually ranks at the bottom when it comes to healthcare access. We are number one in infant death. We are at the top, near number one in maternal mortality. Would you want to have your baby here? Would you want to raise your family here? These are things that families are asking themselves. And so, people unfortunately are making the decision to leave. But I think that we definitely need to take a look at these things. And that's the starting point, having our elected officials, tasking them with looking at this information, looking at this data, and investing in better socioeconomic opportunities, educational opportunities, looking at our healthcare infrastructure. Those are things that are really, really important.
And the next question is focusing on mental health, which has been kind of my area of focus for the past year, but sort of in a different context. And increasingly, I think this is becoming part of the conversation nationally around maternal health, but also in Mississippi. Nationally, the CDC recently reported that from 2017 to 2019, mental health conditions, including deaths by suicide and overdose relating to substance use disorders, were the underlying cause for about a quarter of all pregnancy-related deaths. So really spotlighting, not only are people suffering from this, but this is causing deaths that are preventable and related to pregnancy. So I wanted to ask each of you, what have you seen out there in our state that works or that helps with women suffering from substance abuse or mental health issues here in Mississippi related to their pregnancies or otherwise?
So I guess I'd like to start, the answer to this as, for us as an organization, the women that come to us that are struggling with substance abuse, especially hardcore substance abuse, report that a lot of times they are introduced to these heavy drugs for pain management from oftentimes pregnancy-related complications and unnecessary cesarean births. So we kind of have to go back, and I say again to the healthcare community, to be responsible, because now we're introducing new problems to a person that probably could have very well equally have benefited from talk therapy, peer support. It didn't necessarily have to go to a level of opioid to manage pain. So we're introducing oftentimes our own problems, and then we're looking for the solution. Well, the solution is see her, hear her, and as she's in your office, don't be so quick to hear only the pain speak, but also look back through her charts, look through her family history, of addiction. Look through her medical history and family history of behavioral disorders, mental health disorders, because what you prescribe for one, you may not prescribe for all. So I challenge us to think of individual care models, not a one size fits all. And for as the lower grade ones, I would say tobacco, alcohol, marijuana, what we're seeing with those reporting of using those substances is usually oftentimes to mask something. It's past family traumas, it's domestic violence, sexual violence, interpersonal violence, it's financial stress and strain. So those that report to us, using those substances are oftentimes just trying to simply mask a pain that has not been fully healed. So.
Yeah, absolutely. We really have to work harder to do a better job of taking care of our mothers. That's just a fact, not just here in Mississippi, but abroad as well. Mothers wear many hats. They take on a lot of caregiving responsibilities. And again, when I mentioned earlier that with motherhood comes a wide range of emotions, good and challenging. And we need to do a better job of making sure that we're infusing or funding into community-based organizations that are women-centric, that are mother-centric, to offer this kind of supportive services and resources that women and mothers need. So, and unfortunately in the state of Mississippi, we do not have an abundance of substance abuse or substance use treatment programs and facilities that are accessible to women, specifically mothers as well. And when I think about the community action-oriented organizations that are available, like the Mommy organization,
Thank you, friend.
like Six Dimensions, Magnolia Medical Foundation, Healthy Start is great as well, Jackson Safer, but a lot of us are clustered and we're based here in the more metropolitan areas. What about our rural areas? Most people live in rural areas. And so we have to think about making these services more accessible to the broader state, those who, aren't so reachable.
I agree. And I would also add one last thing to that, LaJune. Does anybody in the room know exactly how many inpatient treatment facilities there are for women and for women that offer the ability to bring their child along as they are seeking mental health services? Yeah. See, you can count on one hand, I can tell you that. As an organization, we've been able to find 2, but I think I have heard that there is maybe another one on the coast that I've not been introduced to, and that's Catholic Charities, I believe, in New Beginnings. So we're talking about a total of maybe 44 beds. And I think Isabella and I, we talked about this, that out of those beds, if I'm a mother and I'm not experiencing challenges with substance abuse, I'm just going through a little fog and funk right now mentally, do I want to be housed in a facility that also has someone that's struggling with substance abuse and other things? So I think we need to look again at the resources or the lack thereof within our state, because that is an anxiety. And that was actually one of mine, if I could share my personal story, that, oh God, I felt like my daughter hated me. She cried morning, noon, and night, on the boob or not, dry, clean, fresh. She just cried. I mean, one of the worst cases of colic I had ever seen. And it got to a point to where I just wanted to put a pillow over her head. And it wasn't to kill her, it was for peace. If you've ever heard a piercing cry of a baby, nonstop, and no matter what you have done that everybody tells you to do to make a baby hush, and she still cries, it sends you into a mental state like none other. So was I to a point to where I would check myself into a mental treatment facility? I probably would have had we had those services available, because it got that bad for me. I was to the point of suicide. I called home one day and told my mom, come get your grandbaby, because I don't care if I live or die anymore. Like, that's my story. But my story goes back before, and as I was pregnant with her, I had morning sickness severely, to where I'm getting infusions. Like, I couldn't keep anything down. She wanted everything, but then when she got it, she made it come right back up. So if you've ever vomited to the acid in your stomach, it is painful. And to do that every day almost for 7 months, you know, it's not blissful for you. And then to find out that your delivery story is that you've had a placenta abruption, she's almost out of amniotic fluid, we have to have an emergency C-section. Wait, what? My bikini line is now gonna be no more? Like, I didn't have time to sit and think in the decision. But on top of that, I'm thinking about, well, how long has this happened? The doctor just came in and scared the crap out of me, because he said that it's a possibility that she may have some brain damage. So now I have to wrap my head around, what if I have a special needs child and I'm only 21? The only information I remember receiving in the hospitals, and kudos to them for pushing breastfeeding, but that's the knowledge that I got, was all about breastfeeding and the importance of breastfeeding for my healing and for the development of the child. But I got nothing to say that you mentally may not be okay after having this child. And with me being a high-risk pregnancy, me being several risk factors that someone should have caught. I had an unwanted pregnancy. I knew I was gonna be a single mother. And then to have an emergency C-section, and I have to make this decision here and now. Like, I was missed, Mississippi. How many other women are being missed, Mississippi? I strongly urge us to look inward. And as I grew the courage, 13 years later, I met a man. God, it's always a man. Met a man and decided to have a child with my husband. I knew I did not want to feel the same way that I felt before. I wanted to enjoy and to feel what other people around me had felt with having a happy and wanted pregnancy. But I still ended up getting anxiety. Naturally, right? All those thoughts came flooding back in. And I want to be a good mom. Still no resources available. 13 years later. So I did what I always do. I tried to become the solution as much as I can. So as much as I hate sitting on these stages, y'all are beautiful and handsome and gorgeous, but I do not enjoy public speaking. But I do it, why? Because I have to. Because if my story can save someone else merely by me having the courage to share my story, then I'll do it every day, all day long, and I may not charge you.
Thank you for sharing that. And I think that, I mean, it's really powerful to hear your story, and I think that also speaks to the power of peer support and what you're providing for women involved in your organization and across the state through your advocacy. Really grateful to have the benefit of you sharing your experience. And the backdrop for this conversation, and I think something that maybe if there are folks here who are not from Mississippi, definitely know about us when it comes to maternal health, is that the Dobbs Supreme Court case that overturned Roe, of course, originated here. And since that decision, Mississippi has a near total ban on abortion. Only exceptions are rapes that have been reported to police and when the life of the mother is in danger. And I wanted to ask how each of you are seeing this ban affect our state so far. Lejeune, what are you seeing in your work?
Sure. So whenever the Dobbs decision is a topic of discussion, or we talk about Roe v. Wade and what reversal and what that means for the state of Mississippi, I'm always reminded of our state health officer sharing that there will be 5,000 babies born in light of the Roe v. Wade reversal. There will be now 5,000 babies born, additional babies born every year as a result. And so I think what that means for the state of Mississippi, dire consequences. And those dire consequences include an already overworked, overstressed healthcare system, our already overworked and stressed maternal healthcare system. We're struggling right now to take care of the folks we got here. We're struggling right now to ensure that women can deliver babies safely, that our babies can be birthed under more positive health care outcomes. Unfortunately, like we mentioned earlier today, Mississippi is #1 in infant death, and we are near the top in maternal mortality rates as well. So we can conclude that those numbers may likely go up even more, unfortunately. We also can conclude or make the assumption that our child welfare system is also going to be challenged. It's already challenged right now. Right? We don't have enough homes for the children who are already in the child welfare system. And so, again, we have to tax our elected officials. What are we going to do about this? What are the solutions? What are the answers? I'm hopeful. I think that's why we're all here. We're hopeful. We are optimistic, and we all are here because we're passionate about improving maternal and infant health in our state. So,
And I think if your stance behind that decision is to in support of the child, then what is the long-term effects of a child being born to a parent that basically does not or is not ready to be a parent, right? So we're thinking about the child in the now, but what are the effects on this child later? That could look like several different things. As LaJune mentioned, that could look like more child abuse cases. That definitely looks like a rise in mental health services, not only for the parent, but for the child, because the mental stability or instability of a mother is oftentimes fed down to the child. So we're looking at adolescents that are now experiencing mental health problems and behavioral problems, all because of what was not received in the beginning, whether that's love, support, nutrition, whatever. I think, again, if the overall is looking at the fetus and the unborn child, I challenge us to think through that decision and what does that look like? What are the supports that we have here that support the decision is what I'm asking. And does everyone in the birthing community, these women, do they know of the supports available to them? The counseling services. Because if I had the thought in my head of possibly terminating my child and I decide to keep it, guess what? I'm going to need mental health services to walk me through that challenge. And then on the flip side of that coin, if I decide to terminate, which is no longer possible in some cases, I too still need mental health services around this decision. So again, what are the supports to support the decision? Where are the funds to fund longevity of the organizations that are on the ground performing the work, that are backing or looking to provide services that back your decision?
And I want to make sure that we leave some time for questions. I don't know how we're doing, but one of the things that I wanted to kind of make sure that we touched on is barriers to care that people face. Last year when I was reporting on Dobbs and starting after the decision to do more reporting around maternal health and, what is the situation we're in currently, and talking to OB-GYNs all over the state, one of the things that I heard was, it can be very challenging for women to get to prenatal appointments. People face barriers including transportation, childcare, getting, your Medicaid approved can take a really long time. It seems like in the last few months, those approval timelines have actually increased. It seems like it's taking longer this year than it did last year to get your Medicaid approved. So I wanted to ask, what do you see as kind of the biggest barriers that women face in accessing care when maybe it is available to them, they can get an appointment? What makes it challenging for women to access the prenatal care that they need?
Oh, I was just going to say definitely transportation is one. We're a rural state. I'm from a little small town where it's so small they took the one stoplight down and put up a four-way stop sign because it financially wasn't feasible. So looking at that, especially if we talk about like the Delta and hospitals closing and stuff like that, and we think through transportation, I know these rural towns, they are dark. Somebody has shot the road sign down if it's still up, so you don't know where you're going unless you're from the area. And then you have cellular services or the lack thereof. So if I have an emergency, I'm already 30 to 45 minutes away from the nearest emergency management facility. So we're looking at a response time, and y'all have seen it on the news this week with the response time here with emergency services responding locally. So can you imagine what rural Mississippi looks like on response times? So you're talking anywhere from 30 minutes minimum to get a response to an hour sometimes before you can make it to an emergency facility to receive life-saving care. So transportation and the landscape of Mississippi as it stands definitely is an issue, I would say.
Yes, absolutely. I also think there are a few things that we can do to make Medicaid more accessible as well. I think that when we look at Medicaid, the application itself is not particularly user-friendly. It's a 28-page application. And that's very intimidating. I've seen the application. I've had moms, approach me, as a social worker with a lot of questions, not quite understanding what is being asked, having trouble navigating the application. I think first step is definitely we can take a look at shortening the Medicaid application, making it more accessible and user-friendly. We can also adopt presumptive Medicaid as well. Other states have done this as well, and I think that's really important. Unfortunately, there are not a lot of providers that take Medicaid. Because of the challenges with dealing with Medicaid, you run the risk of not being reimbursed for services. You also run the risk of not being being paid at a reduced rate or not being paid at all for your services, which is challenging. So a lot of providers don't even bother to be in network with Medicaid. So we want to incentivize providers wanting to be Medicaid providers in general. And I think, more providers would be, more likely to be in network with Medicaid if they thought that, if we had presumptive Medicaid. So I think those are a couple of things that we could work on just to enhance access.
And just very quickly before we turn it over to questions, if each of you could flip a switch, you have infinite money, you have infinite political capital and will, you get to make one change to improve maternal health in our state. What do you do? What does that look like?
Medicaid expansion. And here's the thing. Okay, so yes, we have adopted postpartum Medicaid expansion, but we need to be looking at our sights towards the future. Medicaid expansion also would help our mothers and our babies in our state as well. When we look at the data, there's just really no reason for us not to have it. We are one of 10 states that do not have it, and all of the data about Medicaid expansion, shares nothing but positive things. It's going to increase our revenue. It's going to bring jobs to Mississippi. It's going to strengthen our healthcare infrastructure is near collapse, y'all. And Medicaid expansion will help these rural hospitals stay open by, making money through the reimbursement rates. So, I mean, if we could I think that's a great start. We still got work to do, but that would be a great start to get that approved. And actually, if we look, I think I saw the latest poll about this, most Mississippians want Medicaid expansion from the last poll that I saw. So, again, turning things back around to our elected officials and really holding them to task, why don't we have Medicaid expansion? If the people are saying they want Medicaid expansion.
In agreement with LaJune, I'd add that we need more funding for the community-based organizations. And one reason I say that is because our community trusts us. We are the ones that are in the community. So oftentimes, we're the one convincing them to go to these follow-up appointments or seeing a dentist, seeing an eye doctor, whatever it is the community that actually are the ones that oftentimes really can help push that needle in healthcare. Because again, we are the trusted communities. And I'm talking about not just organizations like mine. I'm talking about your churches, your pastors. These are people that we lean on and that we trust, because trust within our community with with elected officials, it does not run deep. I'm just going to tell you. So if you're standing behind a podium and you're reciting something to me and there's no heart, there's no felt in it, do I believe in what you are selling me? Probably not. So I would definitely say look at adequately funding community-based organizations that are doing life-changing work and that has the heart in the work that they are doing for their community.
Well, thank you so much, LaJune and Lauren. And we've got about 5 minutes left for questions. If anybody has a question, I think, we're a small group. We might be able to hear you from your seat, or you can come up to the microphone.
Who are the people who lobby the state legislature for women and babies?
One really good organization, I believe, is Black Women's Roundtable. Miss Cassandra Welshland, I hope I pronounced her name right. She's, I always jokingly say, a powerful, Black, beautiful woman that I am ecstatic and in awe of, my girl crush. But her organization does really good work and very knowledgeable and has the resources that lobby for the work that we do. So, yeah, I would definitely include Black Women's Roundtable.
Question, Dr. Henderson?
Thank you both so much for your presentation. I appreciate it. And I'm Anita Henderson. I lobby the legislature on behalf of women and babies as well. And just to let you know, we are going to be lobbying. We've got bills coming forward this year for presumptive eligibility for pregnant women. So we're very hopeful that 12-month postpartum got passed last year, presumptive eligibility this year, and maybe more. But I would tell all of you here, your voices to your own legislators, to your representative, to your senator, to your governor, speak volumes. When you talk to your personal representative, that is beneficial. I have a relationship with mine. Call them on the off season, so call them now and tell them what your concerns are, because your voice is powerful as well. But we're up there in the Capitol working on moms and babies.
Thank you for your service.
Thank you.
I think we are at time. So, yeah, thank you again, Lejeune. Thank you, Lauren. Thank you, everybody, for coming and for your questions and comments. Really appreciate it.